put you guys in a couple of rooms, and I want you in your groups to come up with the differential for the associated picture with the case. The case is a 42-year-old female with 4 weeks of subjective low-grade fever and cough, is now presenting with the following skin findings. So let me see. Create rooms. Okay, so what I will do, move to breakout 1. Okay, so group 1 is going to be Alvin, Anita, Chantel, and Hillary. Group 2 will be James, Omar, Sahaj. And group 3 will be John, Lauren, Matt, and Naman. I put the Google Doc that has the pictures in the chat, so just make sure you open it up on your end. And I'm going to open up the rooms and give you a couple of minutes. Put you in group 2. What was that? Oh. Let's see, who should I put in? 2.
Maybe I'll put it on another time tomorrow, Tuesday before the Tuesday lecture.
Oh.
Or after, maybe before.
Okay, yeah.
I think you might have had some late additions, like Allison and Sam.
I know, I'm trying to put them in rooms right now.
Oh, do you need my help?
It looks like everyone's assigned right now, but I see Ellie.
Oh, some people they don't.
Yeah, I'm not assigned. Sorry.
Oh, no worries. Did you get the thing?
I'm on my phone, so because I'm walking to GMA, so maybe that's why I don't see anything. Let me check the more button.
Okay.
Meeting settings, maybe.
Let me see if I can do this again.
No, Ellie, do you see it's like a square box in the top corner, the top left corner?
Square box. Oh, yes, I do.
Yeah.
Okay, got it. Thank you.
Yay. Haha. IT support, always there for you.
Look at you. Ugh.
You know the picture with the white on it? It almost looked like a face. So I keep trying to make it into a face.
Ew.
Yeah.
Oh, hold on. I'll put Ed in there. Okay. So I'll close it in a minute.
Ba, 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 beep, 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 ba, 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 boop, 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 boop.
Navi, sometimes I wonder if you do that at home because silence is just a struggle for you.
The answer is yes. I'm constantly humming to myself.
I'm not surprised. All right, looks like everyone's coming back. So whoever took case 1 or was in group 1, give me a differential for what you think this is.
So I think we were a little kind of confused by this. We weren't sure if it was kind of a different presentation of erythema nodosum, but it looks like it's kind of scaly, a little silvery. So I mean, we threw out psoriasis in there, but as far as endemic mycoses that present with that, we didn't really have a good idea.
Great. Hold on one, oops, that gave it away. Hold on one second, I'm just gonna increase my volume a little bit because I'm having trouble hearing you. Okay, Alvin, can you talk again?
Yeah.
Okay, great.
You hear me better?
So let me just share again. So what I heard was you said a different presentation of erythema nodosum, psoriasis. Did you say anything else?
Not really, no.
Okay. All right, great. So great job. This group 1, that picture is actually varicose lesions that you can see in specifically blastomycosis. What this is, you'll see the overlying, this white shiny, it does kind of look like psoriasis. It's actually little micro abscesses within the epidermis, and you get this proliferation of that layer of the skin, which then kind of shows like this. So really good job. So specifically, this is in blastomycosis. All right, what about group 2?
Weren't super confident in this answer, but we were thinking maybe a histo or coccidioid.
Perfect. Yeah. So what specifically are you seeing here?
I can't remember what the names of them are, but the lesions on the shin.
Yeah. So the erythema nodosum, those painful skin lesions that like kind of come up as nodules. So yeah, exactly. This case specifically is histo, so you are right. And the pathophysiology is it's a delayed hypersensitivity reaction. All right, and then group 3. This one was a little harder.
So at first, I didn't realize that the lecture was called like systemic, like fungal type things. So I was thinking this is erythema multiforme just because it looked like targetoid lesions. But then talking to my group more, we thought it actually could be a cutaneous manifestation of aspergillosis.
Oh, interesting. Very good. So in this case specifically, this one's interesting, and I actually didn't know about it until I started looking into this topic. But this is Sweet syndrome, which can be caused by coccidioides. And what that is, it's an acute neutrophilic dermatosis. So you get infiltration of the dermal layer by neutrophils. But that was a really great differential, Lauren. All right, so I gave it away a little early, but we are going to be talking about endemic mycoses within the US. So I'm going to start off and make all of that pre-med knowledge from college worth it, and just review what the fungi kingdom is. So if you remember, they're eukaryotic, and the two forms that exist are yeast and mold. So your yeast, they're single cellular, but they can reproduce by that budding or binary fission, if you remember, whereas mold are multicellular. You can develop like long filaments, septate hyphae, and they actually grow by apical extension. Now, some fungi actually share both of these forms. You might have heard the word dimorphic, meaning share, like holding two different forms at the same time. So the endemic mycoses specifically can be either in yeast form or in mold form, depending on the temperature. So when it's warmer, they exist in yeast form. When it's cooler out, they exist in mold form. So in the environment, when it's cooler, they're usually in mold form. In the body, they end up being in yeast form majority of the time. I'm not going to go through every single fungi listed here, but I'm just showing you this to show that the endemic mycoses exist in the dimorphic category. Specifically, since we're going to be focusing on endemic mycoses within the US, these are the three we will be talking about: Coccidioides, Blasto, and Histo. Paracoccidio is actually more Central South America, so we're not going to be talking about that today. So the reason I'm giving this talk is I always had a lot of trouble differentiating these three, besides knowing like the characteristic locations. So I kind of wanted to make that a little easier for everyone. So before going into the differences, I want all of you to think about the similarities they all share. So can someone list some for me? The first one I'll give to you because we already talked about it. These all are dimorphic, meaning they can exist in either yeast or mold form depending on the temperature. So you can either write in the chat or call out any other similarities these three share. And I'm really good at waiting. Okay. Yeah, Sam, they all can cause respiratory infections. Perfect. So what I will give you as a shared finding, so in addition to respiratory symptoms, they all can cause cavitary disease. What's interesting about cavitary disease is this is more common in people with pre-existing lung disease. So someone who has emphysema, for example, that person's more likely to develop cavitary disease. Besides respiratory disease, what can all of these cause? Let's try that. Cutaneous lesions, great, guys. Yeah, Candace, so basically all three of these can affect any organ in the body. So let's just make that easy for everyone. They can all cause disseminated systemic symptoms. Another one is the way you're inoculated is you inhale spores of all of these, okay? So, and there are a couple of more, so I'll just show you. So we already talked about, they're all dimorphic. You can inhale spores. They all can cause pulmonary infections and cavitary disease in people who have pre-existing lung conditions. They all can cause disseminated infections, and they all can affect every organ, essentially. Every single one of these, this one we didn't talk about, treatment will involve an azole at some point. And then this one's important. Severe disease happens in people who have T cell dysfunction. So, you know, anyone who's on an anti-TNF agent, has HIV or AIDS, or a solid organ transplant is on the appropriate medication. Okay. So now that we have the similarities down, let's start talking about differences. So I have a couple of cases. I'm going to put you all in breakout rooms again. I want all of you to come up with which of these 3 mycoses you think it is. And for extra credit, tell me what manifestation of the mycosis it is. And if you want to talk about it, just like other things, you know, these fungi can cause other infections. So I'm going to send this Google Doc again, if you can open it up before you go into your breakout rooms. And so, let's see, group 1 will be Alvin, Anita, Candace, Chantel, Hillary, Jesse. Group 2 will be Ed, Ellie, Jill, James, Omar, Sahaj. And then group 3, Allison, David, John, Lauren, Matt, Naman, Sam. Okay? So I'm going to open it up and see you all in a bit.
You know, I think one of the Friday email memes this week would help people.
Yeah. I read all of them.
I think maybe it was this week, maybe it was last week, but I think one of them was related to number 3.
Oh. I'd have to look again. Nick would know.
Sorry, what?
Navi said one of the Friday email memes would help people out.
Which the recent Friday email?
Is there a Valley Fever? Or?
Oh yeah.
Oh.
No, wasn't it Coxie? Okay.
Oh, I'm muted. Yeah, there was one on Valley Fever. I'm trying to find it, and I think I just did. It's an old woman talking to a man, and it says, "My patient with fever, joint pain, and erythema nodosum." And then the caption says, "What the hell's in New Mexico?"
Yeah, dude, that Lord of the Rings one with the medicine, it's so good. I still think about it. You saw that one?
I didn't read all of it.
Oh my god, this is my favorite meme that Navi has ever made. Let me find the names.
You're talking about the "Give him some medicine, boy." That one.
It's like so good.
I literally made that one from scratch, and I'm so happy I went through that effort.
I feel like you wanted to make that one for a while.
You know, I had it in the back of my mind, and an artist, you know, they just need to find a medium.
Let me try to find it. Wait, this is buried.
I thought that Nick might have a few favorites from this week too, but I don't think he did.
Wait, did I look this? I don't know if I looked at this one.
You know, I hope you do, because there's a lot of medicine ones this week.
Which one was this week?
It was The Walking Dead.
Wait, I thought I texted you the ones I liked.
Maybe
I didn't. I'll take a look at them again.
Like, I think there's one on Little syndrome for no reason.
Okay, maybe I'll show you later. so good. No, it doesn't. This is patient and cardiogenic shock.
A good one.
Medicine, boys.
All right, guys, I think everyone's back. So let's go to group 1. All right, group 1, what did you think this was?
So I think we were thinking, since it's in like kind of that Lake Erie, Mississippi River Valley area, we were thinking more blasto with the animal areas and exposure to animal droppings. I think we were thinking still blasto and potentially histo as well.
Sorry, what was the last thing you said?
With the exposure to animal areas, so exposure probably include histo with blasto in the differential.
Histo with blasto. Okay. And is there one you think this was more so?
I'm going to say blasto, but don't ask me why.
Okay. All right. Well, that's what this talk is for. So this one specifically, I'm actually trying to get at histo. And you did include it in the differential, which is great. So specifically, animal areas, this Mississippi River Valley region. And then what I'm trying to get at here is the disseminated form of this disease, and like getting close to shock, which is very common in specifically histo and in someone who has a transplanted solid organ. Okay, so, and we'll get to all of the risk factors for each group to help make that a little more clear. So in talking about histo, like you said, this is in the Mississippi Valley region. So that is the first risk factor. That's what you're going to see in your vignettes. So, you know, it's kind of roughly in this region, okay? So that's where you're going to be seeing histo. So other risk factors for histo, you know, you mentioned animals. So specifically bird and bat droppings. So when you think about animal areas, you might be thinking about like chicken coops. That's like a very typical vignette. Someone whose hobby is going and exploring caves or spelunking and then hanging out in wooded areas. So now let's talk about all the different presentations. So, I'm going to actually give these to you just to help differentiate. So I like to differentiate histo specifically and all the other mycoses into pulmonary primary disease versus disseminated disease. So your, acute local pulmonary infection, that's essentially presenting like a pneumonia, okay? It's, you have exposure within 4 weeks, you develop fever, shortness of breath, cough. Oftentimes the cough will be more so of a dry cough rather than, your wet productive cough. On chest x-ray, you're gonna see more of a localized infiltrate. So if you're from one of these endemic regions and someone's presenting with a pneumonia, it's actually a good, it's good practice to look into, your localized histo infection. Whereas acute diffuse pulmonary infections are different in that you'll have diffuse infiltrates. Now, the way one can really differentiate these two is the degree of fungal burden you're going to have as well. So with acute diffuse reactions, I think of that as like a much more severe form of a pulmonary infection. So you will have a higher fungal exposure burden than in your localized infection, okay? Now, your chronic pulmonary infection is someone who will develop cavitary disease. So again, like I said in the beginning, think about your patient who has prior lung disease like emphysema, COPD. This patient might actually experience a little hemoptysis. It'll be milder than, you know, in something like aspergillosis. Before I move on to disseminated disease, some of you might be thinking like, hey, I've had someone who had localized lung infections, but also had, you know, other symptoms like joint pains and maybe pericarditis. Was this actually disseminated disease? The answer to that is no. So you can, in pulmonary disease, actually have various inflammatory syndromes. This includes like your arthralgias or arthritis, your pericarditis, when you have your mediastinal lymphadenitis. So this is all inflammatory, and we'll get into treatment a little later, but rather than treating the inflammatory conditions with, you know, your fungal coverage, these can actually be treated with NSAIDs specifically, okay? And then, you know, when I think about chronic disease, I think that it's taken a long time to develop, over 4 weeks. So your fungal burden is actually on the lower side. Now we get to disseminated disease. So the people that are most often affected or most often develop acute disseminated disease are those who have T-cell dysfunction. So your organ transplant patients, your patients with AIDS. This is very severe disease. So like our vignette, this is someone who has developed shock. They've maybe developed a renal failure. And then every once in a while, you'll see someone who's developed ARDS. So rather than staying in this acute diffuse pulmonary stage, they develop like end stage lung disease. Again, the way I think about fungal burden here, more severe disease. So we're going to have higher fungal burden exposure. And then finally, there's your chronic disseminated disease. So yeah, this could be someone with T-cell dysfunction, but it also could be someone who has pseudo depressed immune states, so like an elderly individual. What you can have here is, you know, your pancytopenia or bone marrow suppression. You might have adrenal disease, organomegaly, things like that. Again, I think of it as a lesser form or less severe, so you get less fungal burden in this disease. Now, the meat here is the testing. What I will say for histoplasmosis, honestly, none of the tests are beautiful, but in your acute diseases where, you know, treatment management is a little time sensitive, your urine and serum antigen testing is very, very helpful. So what else? So I'm gonna just fill that in for ease sake. So urine, serum antigen, urine, serum antigen. So again, acute local disease, acute diffuse disease, and an acute disseminated disease, I would just get these from the get-go. The sensitivity and specificity increases when you get both, and both are positive. You know, the IDSA and ATS guidelines actually recommend, no matter what, getting 2 forms of testing to increase your sensitivity. For chronic pulmonary, like localized disease and chronic disseminated disease, they actually recommend getting, you know, sputum, blood, urine, BAL cultures. Same for over here. or, you know, actual tissue. The issue with these is it takes longer. You have to wait a longer amount of time. So that's why in the meantime, you can get your urine serum antigen testing. The serologies or antibody testing really isn't super helpful. Oh, let me see. So Candace asks, is there a problem with false positives like in Fungitel? If a patient gets antibiotics prior. Candace, do you mean like if someone's had a prior infection years ago, like do they have sustained serologies?
No, I mean, like if patients get like Zosyn or ibeta-lactam before like testing for Fungitel or galactomannan, they can have a false positive just from that antibiotic exposure. And I wasn't sure if you're testing for like histo antigen.
Sure, yeah, that's a good question. I didn't read anything about that specifically related to receiving antibiotics prior. What I did see is, you know, there is cross-reactivity with other mycoses like blasto. So, you know, the clinical vignette is actually really important here, but I didn't see anything with prior antibiotic exposure.
Thank you.
Okay, so, you know, this next slide is just the cleaner version of what I just did, but the big picture is for testing for all of these. Get, you know, your urine and serum antigen, really helpful in acute disease, but no matter what, try to get 2 forms of testing, whether it's antigen and culture or antigen and biopsy to increase your, you know, your sensitivity and specificity. Okay. All right. So group number 2, what did you guys think this was? So I'll read the vignette for everyone. 52-year-old male from the Lake Erie region presents with continued cough and fever. He was treated with 2 separate courses of antibiotics for presumed pneumonia, noticed minimal improvement. He works in forestry and said it's been hard to complete work-related activities. So anyone from group number 2?
We were thinking blasto, just based really on the location.
Based at like the Lake Erie region, like that. Great. And for extra credit, did you guys think about like what manifestation of blasto this is?
I think it's just like primary pulmonary, or maybe like a chronic phase, just because it sounds like it's been going on for a while.
Perfect. Yeah. So it is a chronic pulmonary infection. The other, so we'll get into why, you know, continued treatment, or like, you know, having a presumed pneumonia and failing antibiotics is helpful for blasto. The other thing is just this exposure right here, forestry. So we'll get into that. So again, let's talk about biggest risk factor or most common risk factor. So that's your location. So it's kind of similar to the histo region, but just like a little more narrow, a little higher, I'd say, a little more north. So right about here, I'd say. So it goes towards Canada, more so than histo, but basically a lot of the states are the same. So in terms of common risk factors, so I would think about activities where you work in wet soil. So farming, forestry, hunting. So if they include those things in the vignette, that is, you know, that should point you towards blasto. So in terms of following the course of blasto, it's actually a lot easier than histo. So follow me with this diagram. So a lot of people can have asymptomatic infection. So that means, you know, no symptoms, or they can have, you know, your typical acute pneumonia. This is, it's either no symptoms at all or self-limited and you recover within a couple of weeks, but you have things like fever and cough. What's interesting about blasto is that 50% of people with either an asymptomatic or an acute pneumonia manifestation develop chronic pneumonia. So that's a lot. 50% of people can go to this chronic pneumonia phase. What that looks like, you have your symptoms over a month. The typical vignette is this individual has come into the office multiple times, has gotten multiple courses of antibiotics, and is just not getting better. It'll mimic, TB and cancer, where you're developing night sweats and maybe have mild hemoptysis. And then 50% of those with chronic pneumonia develop disseminated disease. So just remember that, it's very easy to progress to more severe forms of blasto, because that'll be important when we get to treatment at the end, okay? For disseminated disease, the most common things that you're gonna see in life and on your boards are the following. So we already talked about your cutaneous manifestations, the varicose lesion, but you can also get your erythema nodosum. Some people develop arthritis and osteomyelitis. You basically, from the joint or even from your skin lesion, get a draining sinus all the way to the bone, and that's how you develop osteo. You can get genitourinary disease, so prostatitis or orchitis. There are a few case reports of ovarian abscesses. And then you can also get CNS disease, okay? So big takeaway from here is that it's very easy. It's very common for people to develop disseminated disease. In terms of testing, so both the IDSA and your ATS guidelines, they recommend 2 forms of testing because honestly, none of them are great. You need that really good clinical vignette because especially with the urine and serum antigen testing, there's a lot of cross-reactivity with histo. So, it's possible to get a false positive. So you need to have the right vignette. So think about that chronic pneumonia patient. Or get, 2 forms of testing, whether it's culture or tissue. Okay. And now last but not least, I think it's kind of given away, but I'll read the vignette for everyone. 35-year-old male working in construction visits from New Mexico. He's been in Philly for the past 2 weeks, developed fever, shortness of breath, night sweats, joint pain, and productive cough. Chest x-ray shows a right lower lobe infiltrate. So group 3, since we know this is coccidio, how about someone tells me like what gave it away and if you can, what manifestation of coccidio this is.
Yeah, we went with coccidio mainly based on geography, with him being from the American Southwest. And in terms of the presentation, we were thinking like an acute local infection with the pneumonia. The other manifestations like the joint pain and skin lesions, we were thinking were more inflammatory in nature, secondary to his primary pneumonia.
Great. Awesome, Dave. Now, before I move on, does anyone remember from, medical school or step studying what the combination of, your pneumonia symptoms, this joint pain, and the painful skin lesions is called? And this is open to the whole group. And there are a couple of names for this. Navi said there was a meme about it in the Friday email this week. All right, so this combination of your fever, productive cough, your joint pain, and the painful skin lesions, that There are a couple of names, your valley fever or San Joaquin Valley fever, your desert rheumatism. Ring any bells for people? Okay, so like Dave said, in terms of location, Southwest US, so just like right around there. And so the risk factors are actually kind of interesting. Rather than specific animals or things like that, it's when you have rainfall in these hot and arid environments followed by extreme heat, what happens is the spores on the ground actually raise into the air and can increase the risk of infection. You'll oftentimes see it in earthquakes, or after earthquakes rather. So rather than, going through every little thing with coccidio, I want to compare and contrast it to histo and blasto. So let's talk about that initial encounter. So, what you will see at the tissue level with histo and blasto, you'll see individual yeast being attacked by your histiocytes, whereas in coccidio, you actually get spherule formation, meaning many spores that are then encapsulated, and then the histiocytes actually attack the entire spherule. In terms of presentation, so for histo and blasto, we talked about those acute pneumonia type presentations. With coccidio, we just talked about it. There's this thing called valley fever, desert rheumatism, where in addition to the acute pneumonia, people also get joint pains and the skin lesions like erythema nodosum. So that combination should clue someone to saying like, hey, rather than a bacterial pneumonia, maybe this is coccidio. There are of course other presentations like disseminated disease that's very similar to the other coccidio, like the other organisms can affect any of your organs. And then in the beginning of this talk, we talked about how this one specifically can cause sweet syndrome as a different cutaneous finding. Now testing, I think this is interesting. So we've talked about how serology really isn't that helpful in both histo and blasto. In coccidio, it actually is. So in the Southwest, the basic practice when someone presents with a pneumonia, an acute pneumonia, they'll often get serology in the initial testing. It might be negative, but what they end up doing is getting weekly serologies, and it's actually relatively sensitive for coccidio. So that is the one difference here. And now we haven't talked about treatment yet. We're going to get to that next. But, for moderate to severe disease in histo and blasto, your liposomal amphotericin is used in moderate to severe disease, whereas in coccidio, fluconazole is your first line. Okay, now the finale, let's get to treatment. So if everyone can remember that blasto slide where I said many people develop either chronic pneumonia or disseminated disease. That is very important for the treatment of asymptomatic and mild infections. So what you'll see is that no matter what, if someone has any form of blasto, you are always going to treat it with itraconazole. Whereas in histo and coccidio, there is the option to monitor for self-resolution. If your infection or the symptoms last beyond 4 weeks, that's when you can start treatment in these people. So itraconazole or fluconazole in the case of coccidio. But just the differentiating factor in asymptomatic to mild disease is always treatment with blasto, whereas you can monitor in histo and coccidio, okay? So now for moderate to severe disease, for histo and blasto, it's the same thing. Liposomal amphotericin in the immediate, and then you do a longer course of itraconazole. Whereas, like I said in the last slide, fluconazole is your first line for moderate to severe disease. If the disease is refractory, that's when you can introduce amphotericin for coccidio. And then finally, some special considerations to talk about. So in histoplasmosis, if you have a known low CD4 count, you should put the patient on an azole, okay? For blasto, if you're immunosuppressed, you have bought yourself lifelong azole therapy. So let's say, you know, you're a solid organ transplant patient and you developed chronic blasto infection, you're going to be on this agent for the rest of your life. And then the special consideration for coccidio, you buy yourself lifelong fluconazole if you develop CNS disease. Okay. And that's pretty much it, guys. Does anyone have any questions for me? I know we went a little over time.